My task is to chat to you tonight about a very small topic, paediatric asthma. Shouldn't take too long, really. I was given a few sort of topics that you guys really wanted me to concentrate on. I'll try to be a little bit interactive. Please, you're welcome to put your hand up, to shout at me, to ask questions, or you can wait towards the end. I will try and speak very clearly because I know I have a strange accent. So this is my favourite question to ask medical students and junior doctors, is to define asthma. And it's actually a very difficult thing to define. And really there's actually quite a push from some prominent respiratory physicians, especially in paediatrics. We shouldn't be using the word asthma at all, because asthma doesn't actually describe a single condition. Asthma describes lots of different conditions that all come under the same umbrella. They have different presentations, they have different treatments, they don't respond in the same way to various drugs, they have different genetic bases. We're not going to get into all that detail tonight, but just to keep that in mind, that really when we talk about asthma, we're talking about an umbrella under which sit several conditions. For the purposes of tonight's talk, it consists of episodic respiratory symptoms, including cough, wheeze, shortness of breath, and nighttime symptoms. In terms of reversible airflow obstruction, what you're looking for is bronchodilator responsiveness, which you can ask about, so that's handy. You don't need to have lung function to show that. You can ask the patient or ask the parents, does the child respond to Ventolin? If you'll either get a resounding yes, or you'll get almost nobody says no, they don't respond to it. They'll either say yes, or they'll say sometimes, sometimes not, which usually means they don't respond to it. Increased airway hyperactivity, which we need to test in the lab, and airway inflammation, which we test with nitric oxide. Those two things are tests that we do in our respiratory laboratory. This might seem like a strange sort of a slide, but the point of this is we often talk about cough and asthma. And it's a major problem because a lot of children are diagnosed with asthma because they cough and they don't wheeze. And I see this term cough variant asthma. And I've spoken extensively with my colleagues, and we all feel in paediatrics that cough variant asthma does not exist. If a child is not wheezing, it's very unlikely that they've got asthma. So be very cautious about diagnosing asthma in a child who's only coughing. This slide is really showing that most cough in asthma is not actually caused by bronchospasm in children. Most cough in asthma is caused by the virus that's causing the wheezing. We know that because we can suppress the cough without suppressing the wheeze, and we can suppress the wheeze without suppressing the cough. So therefore they must have different mechanisms. So in terms of diagnosing asthma, this is the Australian handbook, which is continuously updated now. So we talk about history of recurrent or persistent wheeze, presence of allergies, so we're talking about atopy, absence of physical findings that suggest an alternative diagnosis, a test that supports the diagnosis, and a clinical response to treatment. So really we're looking at three pieces of information to diagnose asthma: a history and examination that's consistent with the diagnosis, a definite clinical response to treatment, and a test. And we can do tests in probably from about 5 years and above, probably 7 reliably. It's harder to do that in younger children. But if you have those three pieces of information, you can make your diagnosis with confidence. Already you can see in the younger age group, in the preschool kids who can't do lung function reliably, it makes it a little bit more difficult. I think it's worthwhile spending a bit of time on the sorts of things that would make you question your diagnosis. I always tell medical students when I get referred an asthma patient, my first task is to try and undiagnose them. And if I try really hard to undiagnose them and I can't, then I'm happy to call them asthmatic. So any of the, I won't necessarily read all of these out, but a couple of things that really stands out. If they've got symptoms from the first few days of life, it's not asthma, because asthma doesn't present in the first year of life. If they've got a very moist cough, now some asthmatics do have a moist cough, but if it's a cough prominent presentation and the cough is very moist, then you need to be very careful about diagnosing asthma in those children. Obviously, if there's systemic symptoms suggestive of another diagnosis, or if, especially in young children, because young children tend to have intermittent symptoms. It's really only in the teenage years that you get really chronic, unremitting symptoms starting up like an adult type asthma. Really, in young children, they're usually intermittent. So if you've got a 6-month-old who's continuously wheezy, that's not asthma, that's something else. So any other signs of systemic disease? Watch out for origin of disease. So asthma is a lower airway disease, so watch out for upper airway signs. And look for things like sounds that are not polyphonic wheeze, so monophonic wheeze, which would suggest a foreign body or a compression of an airway. Stridor. I find it very useful when people talk about wheeze, and I'll talk about this a bit later on, to actually have a little repertoire of noises, which is going to sound a bit odd, but I will demonstrate those to you in a few minutes. This is just a slide to show, this is the distribution of PBS prescriptions for asthma by age. And you can see that over the first 20 years of life, the predominant age where this is presenting is in preschool and early school age children. So, case number 1, 4-year-old, cough for a year, it's intermittent, check. Mainly at night, check. It's got to be asthma. Also wheezes, check. So that's what the parent tells you. So hands up who would be confident and say, this is asthma. It's got to be asthma. What else could it be? Don't be afraid. I'm not going to punish. All right. So what do I do when someone tells me their child wheezes? I always ask them, what do you mean by wheeze? Okay? So wheeze is the most misunderstood word in the English language when it comes to parents. Okay? So the mother says, oh, I've got a recording on my phone, and she plays the recording, and it's this sound. Now who thinks the child has asthma? No, the child has obstructive sleep apnea. That little misunderstanding of the word wheeze, and it happens a lot, will determine that you go down the wrong road or not. Okay? So I get lots of children who come in with asthma medications who have obstructive sleep apnea. The other sounds that they misinterpret as wheeze is a stridor, which is or a ruttle. A wheeze is this noise. Now, some people have little recordings that they play the patients. I just do the noises. I've had a lot of practice. But it's really, really very important to try and pinpoint that word wheeze. So about 50% of parents don't actually recognize wheeze when they hear it, and they misinterpret other noises as being wheeze. It's often confused with all these noises: stertor, stridor, crackles, cough. Even coughing can be misinterpreted as wheeze. And even doctors often, when they've done studies, auscultation studies of the chest, they often don't agree on the terminology. Again, even if there is wheeze, and you've confirmed that there's wheeze, then that doesn't necessarily mean it's asthma, because there's lots of different I'm not going to go through all of this, but there's lots of different reasons why a child will wheeze. Wheeze is a noise of air going through a narrow airway. That's all it is. It's not asthma. It's just a noise of air going through a narrow airway. Case 2, 3-year-old girl, 3 wheezy episodes in the last 3 months. Clear viral trigger, no interval symptoms. Responds to Ventolin. Yes, definitely responds to Ventolin. Who would start a preventer? Anybody? If I put my hand up, will a lot of other people put their hand up? Okay. She presents with wheeze to she presents with wheeze. She's on 4-hourly Ventolin, and she's got mild to moderate work of breathing.
What is that?
Work of breathing. So she's in your office, and she's wheezing. She's taking 4-hourly Ventolin and has been for 24 hours. She's got mild to moderate work of breathing. Who would start her on oral steroids? You would? Okay, good. I'm not saying anyone's wrong. I'm just saying. Okay. So, evidence-based medicine. So this is one of quite a few randomized controlled trials looking at the effect of oral steroids on preschool wheeze. This one is from the UK. And basically they took a group of preschool children presenting to the emergency department. So this was a more severe end of the spectrum. So preschool children with viral-induced wheezing presenting to the emergency department, and they randomized them to receive oral steroids or not. And the rest of the treatment was completely standard, so basically salbutamol and oxygen if they needed it. Their primary outcome was the percentage of children in hospital, either admitted or in the emergency department, and there was no difference. There was absolutely no difference. And this has been repeated time and time again. When they study steroids in preschool wheezers, it doesn't, in a study situation, they don't.
But this is only in preschool?
These are in preschoolers. This is specific to preschool wheeze. So I said at the outset that that the word asthma is too general. We need to be more specific with how we phenotype these kids. So school-age children, different scenario. Preschool wheezers, where there's clearly only a viral trigger, the oral steroids are well overprescribed. There is an alternative, however. So this is a study that was done in Barwon Health, which is down in southeast of Victoria. And basically what they did was they took a group of children with preschool wheezers, so same group of people, not necessarily presenting to emergency, presenting to a healthcare professional. And they randomized, now this was an odd design of a study because they didn't randomize the patients, they randomized the episodes. So if you had 5 episodes in a year, you could have had 1 episode randomized to treatment and the other one to placebo. And the treatment was basically a short course of montelukast, 4 milligrams, minimum 7 nights, but up to a maximum of when you were symptom-free for 2 nights. They didn't find anything very dramatic. There was a significant reduction in healthcare utilization of time off school and parental time off work. But what I find this really useful for is it's very hard to do nothing. Montelukast in general is a fairly benign drug. It works very well in a certain amount of people, in certain people, because of so the pharmacogenetics of it is that if you have a certain mutation, you respond to it, and if you don't, you don't. In a few years, we'll be able to do a blood test, and we'll tell you what drugs you're going to respond to and what you're not. We're not quite there yet. But this is just an alternative thing to giving oral steroids, and I find it really useful to reducing the amount of oral steroids the kids are getting. Question?
Would that be in preschoolers?
Preschoolers, yeah. These are all preschoolers. So, go ahead. No, you're okay.
No.
Okay. So one of the questions that was asked, I was asked to answer is, how do you know if it's viral-induced wheeze or asthma in a preschooler? And that picture tells you the story. You can't really. So this is a really famous slide in respiratory pediatrics, and it was the Tucson study, which was a major birth cohort study. So they took all the children born in Tucson over a couple of years period, and they recruited every single one of them into this study. And they followed them every year, and I think they're now 19 or 20. And then they tracked the ones who were wheezing, and they came up with these 3 wheezing phenotypes. You've got the early transient wheezers who wheeze very early in life. These are the kids who've got RSV and then bronchiolitis. And then they start to grow out of it, and it's gone by the time they hit school. And this is the majority of the children. This is about 60 to 70% of all wheezers that present before the age of 3 years of age. Then you've got the non-atopic wheezers. So in this group would be kids, the ex-premies, the kids who've been smoke exposed, so pregnancy, smoke exposed, born with small airways. For whatever reason, their airways, they're born with less flexible or more rigid or smaller airways. And as they grow, their airways get bigger and they tend to improve their lung function. If you check their lung function, which we don't do, but we can do it in research, this group are the ones with the worst lung function at that age. And then these are the asthmatics, the IgE, wheeze, IgE associated wheezers. These are they're from atopic families. They've got eczema, they've got hay fever, they've got food allergies, they've got family histories, all of those things, and they probably have asthma. However, if they present at 2 or 3 years of age, you don't know what group they're in. You can kind of have a guess, but you really can't tell. So the treatment is the same. So I won't go into that one. What did I do with this one? Oh yeah, and this is considered a window for intervention. So this is a really nice slide showing that preschool children with current wheeze develop asthma by school age have an early reduction in lung function that develops between birth and 6 years of age. So at some point in between birth and 6 years, those children who go on to have IgE-associated wheeze have a reduction in lung function. It's probably between 1 and 3 years of age, and that's when we need to do something to try and prevent the development of asthma. We don't know what that is yet. We used to think really aggressively treat them with steroids. Who remembers that mantra? Whack on the steroids in early life and you'll prevent airway remodeling. We know now that that doesn't work. We haven't figured out how to do it yet, but that's sort of the goal. Confused? I should have put a picture of Boris Johnson up here, I apologise. So this is to remind me to talk about the crystal ball. So I don't know if you get this question, but I get it all the time. 3-year-old with wheezing, will they go out of it? Will you win the lottery? I don't know. So there is some information. So this is the asthma predictive index, and basically it gives you an idea of your risk of growing out of it. So in general, I tell people you're about 60%. About 60% of preschool wheezers grow out of it by the time they hit school. But if the things that it's dependent on, so in other words, the things that make it less likely you're going to grow out of it, severity. So if you're having lots and lots of wheezy episodes, then again that makes you slightly less likely. If you've got first-degree relatives with asthma, if you've got other features of HP yourself, so rhinitis, food allergy. Eosinophilia is slightly less useful because we don't always have blood work. The other thing is if you've got multi-trigger wheeze, in other words, wheezing apart from just with viruses. So 4 or 5-year-olds and you're starting to wheeze with cold weather, but not necessarily with a virus, or you're wheezing with exercise, not just with a virus. Again, that's an indicator that we may be dealing with something that you're not going to grow out of. This is the asthma prediction tool. This is just to show that there's something that you can look at, and then this is the curve. So basically, if you usually sit around the middle, around 60%. If you've got some of these risk factors, then you kind of drag, and I draw this curve for patients because they tend to understand it. If you've got some of those risk factors, it kind of drags you down the predictive curve. So of course that applies to a population. You can't say to an individual, you are going to grow out of your asthma or you're not, but it just gives them a little idea. Case 3, 6-year-old, so we're getting a little bit older, school-age child. Persistent asthma, on Fixitide 100 twice a day. Has some exercise limitation and some nighttime symptoms. So likes to play sport, loves to play sport, but often has to come off, can't complete games, struggles in training a bit, wakes up 1 or 2 nights a week with coughing and wheezing. So we would say that that's not controlled. Agree? Anyone disagree? So they're on a low dose regime, but they're not controlled. So what is the next step? The options. We could increase the inhaled corticosteroids. Hands up who would do that. I don't believe you. Somebody would do it. I would do it. Okay. Add a long-acting beta agonist. Or add montelukast. Okay. So everybody except all the people who didn't put their hand up, all the people who did put their hand up were all right. So you've got to do something. Obviously, the caveat to all this is you're checking your diagnosis, you're checking comorbidities, you're checking environmental exposures, you're checking compliance, you're checking inhaler technique, you're checking all those things to make sure that they're getting the medication that they're prescribed and you've got your right diagnosis. Allowing for all of that, you've got to do something, and all of these three are viable options. This was a really nice study that was done in the States. Again, New England Journal of Medicine, so it must be good. That's not necessarily true, by the way. So this was to answer that exact question. This is 6 to 17-year-olds. Now, this was a wide age range, I would have to say. But it was 6 to 17-year-olds on low-dose inhaled steroids that were not controlled. So exactly like our 6-year-old we just talked about. And they did a triple crossover study. So in other words, if you were a participant, you went and you got your LABA for a few weeks, and then you had a washout. And then you had your leukotriene antagonist for a few weeks, and then you had your washout, and then you had an increased inhaled corticosteroids. So everybody got all of the treatments, and they checked to see what happened. And what you see in B here is probability of best response. So most people responded best to long-acting beta agonists, but not all of them. A considerable proportion of them did not respond best to long-acting beta agonists. Some of them responded best, to doubling your dose of steroids. And another portion of them responded best to leukotriene antagonists. So what is this telling us? This is telling us we have to be personalized and address our treatment to an individual. So it's not a blanket, LABAs are better than montelukast are better than doubling the steroids. Individual patients will respond differently to those interventions. What we have to do as clinicians is put them on a trial. So I would suggest putting them on the trial for 4 weeks. You stop it, you bring them back in 6 weeks, and you assess their response. Why do you stop it? Why would we stop treatment that we're trying? So that we can have a period off. Because what happens in pediatric asthma is it goes peaks and troughs. And if you happen to put someone on a trial of medication in a trough, you're going to get an artificial false positive, aren't you? So they're going to seem like they're better, but they're not. They've just had a good 4 weeks. So you take them off it and you see if the symptoms come back. So each time you do an n is equal to 1 trial, you have to compare a period on with a period off. I know this is time intensive, but if you're going to get the right answer, that's what you've got to do. So some of them will respond better to montelukast, some of them will respond better to LABAs, some of them will respond better to inhaled corticosteroids. So in general though, long-acting beta agonists, and this is because it's been extrapolated from the adults, about 15, 20 years ago, the adult world just went, put everybody on combined inhalers, put everybody on them. And it's coming through again now, new asthma guidelines, even in teenagers, put everybody on combination inhalers. They are overused in pediatrics. There's no role in under 5s. I probably prescribe 2 children a year LABAs under 5 years of age. They should never be used on their own in children or adults. Do a short trial, like I said, and stop them if there's no clear benefit. If you go to Seretide, for example, and they don't respond, do not increase the dose of Seretide. Okay, you go back to your inhaled steroid and you do something else. Leukotriene antagonists are better than LABAs for exercise-induced symptoms in children, and beware of tachyphylaxis. There are certain children, you'll all notice, there are certain individuals with the ARG mutation where if you give them LABAs, they'll stop responding to beta agonists. I put this up because this is a really nice, and this is the other graph that I draw. This is the dose response curve for inhaled steroids based on fluticasone. So you can see, where's my laser? There we go. This is where the money is. These are side effects, the broken line, and this is the treatment response. This is 200 micrograms. As you go up to 200, as you increase the dose of steroid, you're getting a really good increase in response. As you go over doses of 200 micrograms, it starts to flatten out. But you start getting a dramatic increase in side effects, okay? So going over 200, you're really getting very little extra effect in most children. but you're getting lots of side effects. That doesn't mean, now that sweet spot, which is 200 on this graph, in some people it's going to be 400. Not everybody's the same. But for most children, on average, it's 200. Most of the kids that I see are controlled on that sort of a dose. There's very few, especially the younger children, who I've got to go over that dose. Sometimes I put them on combination, sometimes I have to add in montelukast, but very rarely do I need to go over 200. If I do, I think very carefully about it, and I really hammer home on all those other points like comorbidities, like inhaler technique, like environmental exposures. So in adults, remember inhaler doses, there's low, medium, and high. In children, there's only two. You're either low dose or you're high dose. And these are the dose equivalents in the different base steroids. We know the reason we use these doses is because these are the doses where you least expect to get side effects from inhaled steroids in kids. And the main side effect of inhaled steroids in kids is, what's the one that parents worry about the most? Growth, yeah. Are you going to lose half a centimetre in height if you're on Fixitide 200 for your first 18 years? Probably. But if you've got asthma and you need to be on it, well then that's okay. I had a professor who used to tell me, John, no one ever died of short stature. So I've been asked to talk a little bit about inhaler devices. Anybody, any questions at any point, just let me know. I'm going to stop now in a few minutes.
If a child has asthma,
Yeah.
but only with viral illnesses,
Yeah.
there's no history of atopy or allergic rhinitis, is
Yeah.
that asthma?
So yes and no. So some of my colleagues would say absolutely not. It's not asthma. And I say, what are you going to do when they're really frequent? They're having 10 episodes a year and they're coming to emergency. What are you going to put them on? I'm going to put them on Fixitide. What's Fixitide? It's an asthma puffer. And I say to them, so you're going to tell your patient they don't have asthma, but here's some asthma medication. So academically, they're correct. It's not asthma because there are various, because when you actually do biopsy of their airways, sorry?
But you treat them like asthma.
But you treat them like asthma. This is why we shouldn't be using the word asthma because it's confusing. We haven't come up with a better one yet though. So all I'm saying to you is it's okay to use the term asthma. I tell parents, I don't mind if you call it asthma or not. I'm calling it viral-induced wheeze and this is how you treat it. Inhaler devices. What's wrong with this picture? Ever, never put an inhaler, an MDI in your mouth like that. I don't care if you're 10, 20 or 50. You are not going to get any of that drug. These are all the different inhalers, well, not all of them, there's a few of them. But this is the MDI and spacer. This is kind of the workhorse. I'm not sponsored by people who make Fixitide, by the way. I very rarely use this, although I had a patient who came in to me on that today. This is an acute inhaler. Do people use a lot of this in children? I don't tend to use a lot of it. This is a turbo inhaler. So older kids like these because they don't need to use a spacer with them. But it's really important that we're very careful with technique when it comes to those puffers, and we recheck it every single time that you see them. And this is a large. We don't really use. You don't see too many of these anymore. These are fine. We used to say if they're over 6 or something, you use a large volume spacer, but it's fine. This one's fine for all ages. Mask or no mask? What determines that? Age. So we say up to 3. So if they're still using the mask at 4 or 5, really, if they're able to form a seal, I always ask, can they blow a whistle or those party poppers that you blow out? If they can do that, they can use a spacer. It's better for them not to use a mask if they can avoid it because there's less leak. So under 5, MDI and spacer, and then 6 and over, probably, I made that slide a while ago, but probably 8 and over, I would say reliably they can use turbo inhalers and actuators. I'm not talking about PBS criteria, I'm purely talking about the ability of the kids to do it. Why do we use spacers? They weren't designed for children. They're not able to coordinate. Most adults can't do this either. I know because I was a guinea pig in the study. children have increased oropharyngeal impaction. So pure and simple, the distance between the mouth and the back of the throat is very small. It's in the plume, so in the jet of the inhaler, and the particles are all accelerating when it hits the back, and so they're not going to be able to change direction. So for all of these reasons, we always use spacers in children. Now, which are true or false? In acute asthma, spacers are as effective as nebulizer therapy. So in asthma, spacers are as effective as nebulized therapy in adults and children. True. Salbutamol toxicity is less likely with spacers. True. ED length of stay is less with spacers. Also true. Boris Johnson is a spacer. I'll leave that up to you. Well, the answer is obvious. So I do have a few more slides, but I'm quite happy just to stop there and take questions if you would like. If anyone has any burning questions. Yep.
Just in terms of long-acting beta blockers in children under the age of 5.
Yeah.
What is the reason why you don't use it, or why is it not used?
One is lack of evidence.
Because what about 18 months they have muscles that respond, airway muscles that respond to bronchodilators. So I don't understand why not.
So there's a number of reasons. First of all, there's very little. There's actually I haven't seen a single study in kids of that age where they've shown that a combination inhalers actually work. So that's one thing. There have been a couple of studies, but they didn't reach their primary endpoint. Secondly, when you look at the preschool group, you're really not dealing with you're dealing with a very heterogeneous group of kids, like I saw, and an awful lot of these kids don't have asthma at all. And really, what they need, and they're very episodic. And so, if we start prescribing, we're giving a long-acting beta agonist to kids who don't have asthma, and that's the wrong thing to be doing. And also, the risk of there's a certain proportion of kids who will actually get worse, and tachyphylaxis is more common in young children. So the potential for harm using long-acting beta agonists is higher in young children. So therefore, if you've got no evidence for benefit but plenty of evidence for harm, then we shouldn't be using the medication.
It used to be said not to wash them regularly because otherwise for the first few times when you use it, you lose a lot of drug depositing on the wall. So how often do you recommend to clean
We tell them to wash. We absolutely tell them to wash it. We just tell them to. Some of them now you can put in the dishwasher, but we tell them to wash them in warm soapy water. All we tell them not to do is not to really rub it really dry. What you don't want to do is rub away the inside, the layer on the inside, because what happens is you get static electricity, and when the drug goes into the spacer, it just sticks to the outside. So generally, I say if you can't see through your spacer anymore, you should probably get a new one. But we do tell them, we say wash in warm soapy water, let it drip dry on the side, you'll be fine. You can do that as often as you want, but most people aren't going to do it more than every couple of weeks. And most people have multiple spacers. Yeah.
Yes, sorry, I didn't know about the toxicity. There was less toxicity of salbutamol with the spacers.
You've got more control of the dose when you think about it. So remember, when in a child of less than 5, they're going to be put 2.5 milligrams of salbutamol, oxygen and air, well, not necessarily oxygen, but mainly oxygen driven. So there's a higher risk that you're going to give them too much. And so it's easier to titrate because you can't sort of give, you could, I suppose, you could give 1.25 milligrams instead of giving 2.5 and then give the rest of it in a minute. But you tend to be able to titrate the dose a lot better from a practical point of view with a spacer than you do with a with a nebulizer. And we see quite a bit of ventilator toxicity in the emergency department. Oh, I do talk about that, do I? Yeah, so in acute attacks, the take-home message here, the most important signs in asthma and acute attack are your work of breathing and your level of consciousness. So you can if you're not working too hard to breathe and you're bright and alert, you're probably going to be okay. And I use that to eyeball kids, and I say, okay, well, they're not going to probably need to go to ICU. But if they're getting tired and they're purely tiring, then that's a problem. The other thing I always say is don't let O2 sats guide oxygen therapy. O2 oxygen is not a measurement of ventilation. CO2 is how you measure ventilation. That's how the body does it. O2 is a measurement of oxygenation. In other words, how efficiently the oxygen gets through from the alveoli into the bloodstream. And that's affected in asthma because of mucus plugging. So it doesn't necessarily guide you in terms of how severe the asthma. You can have a fairly mild attack, but you can just happen to have a lot of mucus plugging, and so your SATs can look low. Or you can be very severely unwell and your SATs look okay. So if we start pummeling people with Ventolin because their SATs are low, then you're going to overdo it. And in fact, you'll make them worse because you increase VQ mismatch, because you'll always increase blood flow with beta agonists quicker than you'll increase airflow. Does that make sense? I put adrenaline in there because there's some kids who just go downhill so quickly. I mean, within hours they're fine, and then they're almost in respiratory arrest. That we've started to give those kids adrenaline pens. Remember, before we had salbutamol, that's what they used to use for asthma.
Can I be a pain and ask one more question?
No, not a pain at all.
Postnasal drip and the cough.
Yeah,
It's been said that postnasal drip can't cause cough because there are no cough receptors in the upper airway, in the pharynx, whatever. But
of course there are. There are cough receptors in your ears.
that used to be said. And the other thing is it because rhinitis and asthma are sort of related? So when you got rhinitis, you're likely to have some cough irritation, or is it the stuff that's dripping down?
So that's a really good question. So allergic rhinitis definitely causes cough. But when people think about the mechanism, they often think it's postnasal drip. But more likely, it's because their nose is blocked. And because they're not breathing through their nose and they're breathing through their mouth, they're more likely to cough, because mouth breathing is abnormal. Remember what your nose does. It does three things. It filters the air, it warms the air, it humidifies the air. It does all those things. Your mouth doesn't do any of those things. So if you're mouth breathing, then it's irritating to the back of your throat and you're going to cough. And in fact, that's one of the mechanisms of exercise-induced bronchoconstriction, is the drying effect of air that's going directly through your mouth into your airways, and the reactive hyperemia you get from the gorging of the blood vessels that leads to bronchoconstriction. So allergic rhinitis does cause cough, and maybe there's an element of the mucus going down the back of your throat, because it's often worse when you're lying in bed. But more likely it's because they're mouth breathing. And those are the people, when you hear about they get humidifiers and it helps them, it does help them because it's doing the job of their nose. But what you should actually be doing is clearing their nose out, and then they won't need a humidifier because they've got one right here. Does that answer your question?
That's why they often improve when you give them nose spray.
Yeah, absolutely. So, and you're right, rhinitis and asthma very often coexist. And if you've got, I mean, there's reason enough, rhinitis is debilitating enough to treat it on its own merits, but there's definitely a relationship between uncontrolled rhinitis and uncontrolled asthma. Any other questions? Anything at all? I don't know what other. So I think I got asked to talk about mold as well. This is an interesting one. There are definitely lots of epidemiological studies that show a relationship between mold exposure and asthma, and in fact mold exposure and respiratory tract infections in children. Not a lot of studies, there's a few. So the types of molds we're talking about are typically Aspergillus, Penicilliums, Alternarias. And Alternaria is probably the one that's most prominent. That basically grows on fruit and vegetables. It's very difficult though, because when you think about it, if your house, a lot of moldy houses are also houses that happen to be in certain areas. There may be lots of other factors in the home, such as overcrowding, environmental exposure to smoke. So it's kind of a difficult thing to control. But certainly there is some relationship between mold and asthma. Whether mold triggers asthma in the same way pollen does, or whether it just acts as an airway destabilizer. So in other words, if you're just exposed to mold, you won't get an asthma attack, but then when you get a virus or exposure to something else, it sort of sets you off. But when people, I often have to write letters, please write a letter, I need to be moved because there's mold in my house. And you can get these mold reports. People have started coming in. Have you seen any of these? The mold doctor? And they come in and they have all these different molds and all the parts per million or whatever it is. And there's absolutely no reference range. I'm like, so there's mold. I mean, of course, there's mold spores everywhere. It's like saying, they're like oxygen. They're just everywhere. That's something that's coming in that sometimes there's a couple of court cases that they've been used in because people have been accusing people of all sorts. But I think certainly there's a relationship. When I tell people, if you see mold in your house and your child has asthma, get rid of it.
The mold?
The mold. Yeah, exactly right.
That's very difficult because many environments are actually quite humid. Many houses
Yeah.
have got, are not.
Sydney's a very mouldy city.
Yeah.
And that's why it's written, beware humidifiers. Because of course,
it's not working.
that's right, humidifiers promote mold growth. So you go get, a kid has rhinitis, they go and get the humidifier and they get mold and then it all just goes off. So this is a good humidifier and it doesn't humidify the room, it just humidifies the air going into your lungs. Have I said anything tonight that you've gone, oh, I didn't know that, or oh, I don't agree with that? It's all very straightforward, really. There's one question down the back there.
The same one. Given the strong association between food allergies and eczema, as a risk factor, about 40% for eczema, and obviously eczema and asthma, and obviously with the increasing incidence of allergy to peanuts and all the other things, which is going exponentially whilst the other ones are more or less staying stable. What are your comments in terms of breastfeeding and mother's food and prevention of problems further on and association with asthma?
That's a really good question. I often get asked by parents about the relationship between food and asthma. And it's a complex answer. So to the parents it's not. To the parents I tell them there is almost no relationship between food and asthma. And the reason I say that very deliberately, because you get an awful lot of people going on exclusion diets to control their asthma and it never works. And there's zero evidence that it works. But there's lots of evidence that it does lots of harm. And so that's not something that we should be promoting. In food exclusion diets for eczema, it should be done in a very controlled manner. Now, there is a relationship, a very strong relationship between eczema, asthma, hay fever, and food allergy. Who's heard of the allergic march? So the allergic march is this theory of a progress between eczema, food allergy, and you get food allergy because the food gets in through your skin and the body thinks it's a foreign invader, and then you get food allergy, and then asthma, and then rhinitis, and it sort of happens in this order in some people. Of course, we all know that actually some kids have one and not the other, and in some families there's 4 kids and one has each of them. So, but clearly they're all IgE mediated, and clearly there's an association between all of them. But the food allergy relationship with eczema, which is much clearer, is not at all clear in asthma. And unfortunately, it gets extrapolated. So people think, oh, I went on a food exclusion for my eczema, so I should do that with my asthma. And we actively discourage that because there really is no evidence that that's the case. Now, in saying that, obviously, with microbiome, with all of those sorts of things that we're learning about now, it would be foolish to suggest that what we're putting in our stomachs bears no relationship on any aspect of our health. Obviously, all aspects of our health are influenced by what we put on in our stomachs, but we don't understand enough about it to be going on exclusion diets and making concerted links between food allergy and asthma. And in walks the immunologist. Good timing.
Okay. Is there any other final questions?
Just following up the food allergy question, from a practical point of view in terms of how much difference it makes to kids' asthma, how hard do you push them getting tested for, and maybe it might be in the latter talk, but how much are you pushing getting them tested because it shows they're allergic to dust, mite and mould and all the stuff that's in the house, and then going through, ripping up carpets and vacuuming and changing their bed linen and all that kind of stuff?
That's a really good question. So I do, in preschoolers, a lot of the time I do skin prick testing because I'm trying to measure their atopy, because I'm trying to figure out those things that we talked about. Is this IG mediated asthma? Is this viral-induced wheeze? Is this non-atopic wheeze? And that's helpful in terms of managing the patient, not necessarily for that clinic appointment, but going forward. So I'm not necessarily doing it because I specifically want to know exactly what they're sensitized to, but it does give you an overall picture of how atopic they are. When it comes to then managing things like rhinitis or asthma, and if they're light up to everything, then that becomes a bit difficult because you kind of don't necessarily know. And of course, Paul will tell you, you diagnose allergy by history, exposure and reaction. So if they know, a lot of people know they're allergic to dust, or they just know they're allergic to cats. And in terms of the degree we go to, so there's all sorts of things you can do to avoid dust mite, and you can spend lots of money, and you can alter your house, and you can put fans underneath your floors to get rid of the mold, and you can do all of those things. I sort of tell people to be sensible. The studies, there are several studies, and Paul might disagree with me, looking at taking kids with asthma who are sensitized to dust mite, splitting them up, doing lots of dust mite precautions in one group and doing nothing in the other group. And the differences aren't cross-shot now, to be honest. And there's been some negative studies and there's been some positive studies. And taking publication bias into account, in my view, it's probably equivocal. But there's no doubt that environment influences asthma, and we should pay attention to that. But if you already live in a tidy, clean, nice house, is there any value in spending lots more money on extreme measures for dust mite? I don't know the answer to that.
Thank you. Thank you, Dr.
Thank
Widger.
you.
Thank you very much.